Good afternoon, everyone. We are very pleased to be hosting this webinar as part of our Alliance for Innovation in Maternal and Child Health, or AIM, collaborative, which is funded by the Maternal and Child Health Bureau. We are very excited to be supporting the goals that are a part of this work. You can see them on the screen. ASTHO has been working on this issue to support these three focus areas through content on issues like community health workers, early brain development and early intervention, home visiting issues, coverage and care for pregnant women, and issues around churn, and several other content areas. And this is just one of the many ways that we are going to be working toward the AIM access goals. We obviously would like to thank the HRSA Maternal and Child Health Bureau for their support of this webinar. And you can find more information about our funding on the screen. I would now like to turn it over to our colleagues at Family Voices, Melissa Vickers and Bev Baker. Melissa and Bev, I'm going to turn it over to you.
Great. Can you hear me?
Loud and clear.
Okay. Hi, I'm Melissa Vickers. I'm a project manager with National Family Voices, and we're pleased to be co-presenting this webinar with ASTHO and appreciate the opportunity to share some of the exciting things our state affiliates are doing to engage families in shaping insurance policy and programs, health insurance policy and programs. In a few minutes, you'll be hearing from our Family Voices state affiliate organizations in Delaware, Idaho, and Oklahoma. These three states have a great track record for involving families in health insurance and bringing about significant changes through that involvement. We hope you will learn some new ideas to try, as well as approaches to overcome some barriers you might encounter in your own states. Before we turn it over to Ann in Delaware, I'd like to start by telling you a little bit about Family Voices and the work we do. Family Voices is a national family-run nonprofit organization founded in 1992 by families of children and youth with special health care needs to enhance family roles in health care. We work to promote family engagement and partnership at all levels of care, from the individual family to local, state, and national levels, in order to improve health care services and systems. Family-to-Family Health Information Centers, or F2Fs, are Maternal and Child Health Bureau-funded centers in every state in Washington, D.C. They are family-run organizations that help and support families of children and youth with special health care needs and the professionals who serve them. Many of the F2Fs are housed in statewide family-run organizations that also house other family projects like parent training and information centers, parent-to-parent programs, etc. Okay, Family Voices has family-led state affiliate organizations, or SAOs, in 44 states that provide support, information, resources, and training to families of children and youth with special health care needs, as well as to providers, policymakers, and the public on issues important to these families and their children. Most SAOs are also the Family-to-Family Health Information Centers for their state. F2Fs and SAOs provide assistance to families and professionals in navigating healthcare systems, as well as information, education, training, support, and referral services. They provide outreach to underserved and underrepresented populations, guidance on health programs and policy, and they collaborate with other F2Fs, family groups, and professionals to help improve services for children and youth with special health care needs. Family Voices is somewhat unique from many organizations that assist families with children with special needs in that we are not disability specific. We work hard to engage diverse families and help them learn how to advocate for themselves and for other families as well. In the last year, F2Fs and SAOs supported over 995,000 families and over 324,000 providers through one-on-one technical assistance, trainings, materials disseminated, and through social media. We also work with youth leaders through the Family Voices Kids as Self-Advocates project. And now I'm going to turn the program over to Ann Phillips, Executive Director of Delaware Family Voices. Thank you.
Thank you, everybody. I am Ann Phillips, and Director of our State Family Voices, and I'm also the Director of our State Parent-to-Parent USA Alliance member, as well as the Federation of Families and the Family-to-Family Health Information Center. Next slide, please. So Family Voices is very active in policy that affects the children with special health care needs. We are members of many councils and advisory boards, but we're frequently the only voice at the table representing children with special health care needs. So how do we affect systems change? I bring my own perspective as a parent, but I try, when sitting at these tables, to bring in the perspectives from the families that we get our calls from and the families that we meet. Delaware is a small state, and we tell parents that that should be used to our advantage. We have just 3 counties, and in about 2 hours we can drive from one end of the state to the other. It is very typical when attending a meeting that we will be sitting next to the director of state agencies or elected officials. So why wouldn't you want to be at a table with the actual policymakers? Next slide. So some of the strategies that we use to engage families started out traditional, and we had to think more outside the box. Next slide, please. So we started out with traditional trainings of, can you go ahead to the next slide, please? We used trainings with topics including like how to sit on councils and telling your story and so on. But we were able to get great attendance, but really not so many with joining the councils due to those trainings. Next slide, please. So why not join? And we asked parents to focus groups and evaluations, and what we learned was, well, the timing of meetings. When we have our own meetings, we try to do everything in between the buses, between 10 and 2 usually, so that they can get their children off to school and pick them up from school or the buses. And they're intimidated, whether it's the jargon and the acronyms used or too technical. And they also wanted to see results more quickly than the typical slower pace of many of these councils or advisory boards. We did share the feedback with many of these groups, but we didn't see very many changes. Next slide, please. So we wanted to be able to build parents' confidence so that they would want to speak about their issues that are important to them. Next slide. So we personalize the issues. And how we did this is we would reach out to them on a one-to-one basis. We would give them a call and request their expertise. Because we have great data and database, we're able to see who is called about a certain issue, and we could then call and make these calls to parents and ask for their opinions or their help. We might ask them to man a table at a health fair or a conference and explain that they're going to be working with other parents, which usually they love to do. We'll provide positive feedback to them on the phone when they're talking to us about a problem that they called us for, and point out to them what they've already done that's positive, or a skill that we hear that helps them help their children. We will also call and tell them about an event or a conference coming up in our state that we think is relevant to their family, and if they need any assistance with the registration fee, we always put aside in our budget money for that, and we will help some families to be able to attend. We also found that parents, once they feel that confidence, are more likely to give testimony at a joint finance committee hearing than they would to join a council, with the exception if a council is disability specific, or if they know that other parents will be there and that it will afford them an opportunity for networking with another parent. Next slide, please. Well, actually, I forgot to mention, and I should have, we did pre-town hall meetings, and what that is there was an example was when our state DDS system was talking about redoing a waiver for a family support waiver. Based on what I saw and heard from meetings, I was afraid parents weren't going to understand, so I did a pre-town hall meeting explaining it so that when they're asked, what would you like to see, they could really contribute what they really wanted. And we did similar with the needs assessment from Title V every year. We were looking at the numbers and knew that they weren't right about people saying how they had medical homes when we just knew that that wasn't the case. So we did a lot of education for the last needs assessment, and a survey was sent out. And for this state, it was a phenomenal result. We had 200 surveys filled out, which was really tremendous, and they answered it being able to understand the questions about medical home, adequate insurance, and so on. And that caused the priorities for our state to change. Next slide now, please. The fun and games. I'm going to go back. I apologize. So the fun and games is just one example of what we do for trainings and get to parents engaged on topics that can be very, very dry, say insurance or Social Security. And they're usually at typical trainings, they're very hesitant to ask questions, where this allows it, affords it, and requires it. So we put them in teams, and after a first couple of questions, they're questioning the answers, and conversation is starting, and more things are coming out. And I have never done one of these game trainings where we've ever completed the game, which is great because they get very involved and talking and asking questions. And it's fun, and they learn, and sometimes they get angry when they find out about policy. And we then tell them about something that they can change or do or an event coming. And we see many parents follow through. Next slide now, please. So for the MCO call, that is a forum to engage parents that is probably becoming our most popular, and it's certainly very effective. Learning about advocacy does not have to come from an advocacy training. This is called the MCO call, or managed care. Very brief history. It was started by a group of parents many years ago, children with special health care needs, when managed care came to our state. They were concerned because they started seeing changes or cuts to services, and when they went to the then Medicaid director, they agreed to have a meeting, and representatives from both the state Medicaid and the MCOs and these parents would come and discuss what was going on. And now, move fast forward, somehow the baton has been passed on, and now it's my turn, and I am facilitating. But when I received it, I was a firm believer of this forum because it helped me. That's how I learned about it, for something I needed change for my son. And I kept going to those meetings because they were so educational, and I learned so much. So when I was handed this baton, I wanted to revive it. It was now a phone call. It was every other month. And with a lot of great outreach and cooperation from our state Medicaid office, it is now probably 35 providers every call. And the way it works is on the call, after we do roll call and find out who's on the call of what agencies, parents with the issues get each 10 minutes of uninterrupted time to discuss the issue in a non-adversarial forum. And they can talk about their issue, When they're done, anyone and everyone jumps in with question solutions. Instead of saying to the parent, here's a phone number, call that. We all get educated hearing the problem solving, the solutions, or why that policy is in place and why it can't change. So it's been great. An example of how this call has affected change, parents had, since I can remember, been asking for hippotherapy, and it's always been denied, and Medicaid took a stance it's not something they would cover. But after our calls and having occupational therapists explain it to the Medicaid director on the call, right on the call he said he will be putting in an amendment for the state plan for this to be now a covered service, and it is. So that was a huge accomplishment. We discussed the ABA therapy before the CMS final rules, and they were working on it and listening. When I'm aware of a growing problem or that a number of parents with similar issues are going to be on the call, I'm going to give a heads up and request the presence of the state Medicaid office to be on the call, as well as the medical director from the MCOs, and so that they can hear firsthand about a problem and know that it's not an isolated issue. So that is all great, and there's a load of examples that I can throw out. Nursing, when parents bring up about something that happened, sometimes it's a staff member misinterpreting policy, but nobody knows about it until the parents tell everyone. And that's how things are getting changed and fixed. So let's see. If you can go to the next slide. Our monthly calls have given voice to many, many parents. So when parents were getting services cut because we had a new MCO, well, they were let us know, and we helped both the parents and the new MCO understand what needed to happen. And because we have disability law, which is a branch of our community legal aid, on the calls, we requested, and they were wonderful, they issued a one-pager of called How to Manage Managed Care, and we distributed that. We asked ASTHO was nice enough to distribute that, I believe. And that helped parents know their rights. And we still distribute it every month with the monthly reminder of the next call. So another great example of how well the state works with the families on issues of insurance is that, again, we gave a heads up when services were getting cut again for private duty nursing and other services for medically complex kids. The director of Medicaid was on the call, heard the parents and their anger, and asked me to arrange and facilitate an in-person meeting with those parents, which he did. And he not only met with them and listened, but he went to the homes of parents who were not able to make those meetings, that particular meeting. So parents were able to see how their voices are instrumental in systems change. Next slide, please. So the cause and effect of this meeting is that they are more educated, as are providers. We hear from both providers and parents that they're on the calls, but they aren't giving their names. They just want to listen. State agencies are now telling their staff to get on those calls to learn more about how the system is working. We now do, we had our very first MCO call completely in Spanish over the summer, and it was incredibly successful because all of the providers that we have been getting on these calls, staff participate that are bilingual in Spanish, and it was wonderful. And we have another one scheduled. We are able to identify new issues and new problems. Families have learned and understood about the appeals process, and there are more appeals happening because of that, and successfully winning them. We have stretched who's on the call. We include mental health issues because navigating those issues are so difficult. We included over 18 on a new MCO waiver that's now 5 years old. Those are for 18 and over on that particular waiver. So we are addressing more and more people, and more people are learning about the incredible power of their voice, and that the state is there to work with them and include them. Yesterday, a parent called and asked me to go with her to see a legislator because she wanted to create a bill about an issue she discussed with me. I asked her why did she want me to go since she stated it beautifully. And she said, oh, yeah, I can handle explaining it. I just need you for the data. So there you have it. And thank you for listening for my time.
Wonderful. Thank you so much, Anne. And now we're going to turn it over to Angela Lindig, Executive Director of Idaho Parents Unlimited, and Jennifer Zielinski, Program Coordinator at Idaho Parents Unlimited. Take it away, Angela and Jennifer.
Angela Lindig, and I'm joined here with Jennifer.
Hello.
That way you can distinguish between our two voices as we go through this. We'll try not to take up too much time. A lot of what we do with families and engaging families is similar to what Anne talked about, so we don't want to duplicate that. But what we want to cover is some really specific work that we've been doing with children's behavioral health and the managed care organization for our behavioral health systems in Idaho, which is ASTHO, Idaho, and talk about a lot of the work that we've done as a parent-led organization, as well as how we've involved additional families in this process. And I'm not sure if can you all move our slides, or are we able to move our slides? I think I can do it. I can do it myself. There you go. Okay. So the managed care organization, we've been working with this, project for about 3 years at this time. And one of the things that we discovered right off the bat was there was a sudden decrease in services that was taking place under this new contract. And we were really just not sure what was happening. And so we actually, as the family-led organization, began to explore how we could work in an advisory capacity, really, with both the Department of Health and Welfare, Medicaid, and the managed care organization. And so, Jen, if you want to talk a little bit about some of that work.
Yeah, so Optum Idaho decided, based on some of our feedback to them, was to develop a parent advisory committee so that we could provide some feedback on any changes with families statewide regarding the reduction or implementation of their managed behavioral health programs. So what we did when we came to the table, we were able to present to them some case studies that we have been following regarding the reduction of the only home and community-based service, CBRS, and as a result of that, our data didn't really go hand in hand with the managed care data. So because of that, we brought parents to the table who were part of these case studies so that they can discuss that revolving door of increased crisis for emergency room visits or inpatient psychiatric center visits, or even out-of-home placements for their children. And this would be children who are meeting that severe emotional disturbance criteria. And so through that process, they were recognizing that maybe through their own data, they needed to readjust how they were serving families and how they were trying to actually access that information. So moving on beyond that, we then developed a kind of a subcommittee of that group, and then that subcommittee developed a survey statewide to expand on some of that parent voice. And then parents were able to discuss what the reduction of this one service, how that would impact their family as a whole. And then as a result of that, what direction could they go to try to support the family in stabilizing. So our feedback to the department was a lot of brainstorming efforts on implementing some additional services, some things including respite or some other services that are actually rolling out through an actual lawsuit. And
so I'm going to jump in on that real fast because there was an image up on the last slide, just getting ahead of ourselves. So Jennifer's referring to the Jeff D. lawsuit, which is a more than 30-year-old lawsuit regarding services for children who meet that particular emotional disturbance criteria.
Mm-hmm.
So so that settlement of the lawsuit came after we began this work with Optum and Medicaid, and now the two are merging together. But I wanted to mention too, one of the things that we identified right off the bat in these gaps in service delivery was this particular service that Jen's referring to, which was, it used to be psychosocial rehabilitation. It then was renamed community-based rehabilitation services, and then it began to be cut drastically, and it was the only community-based service for mental health that was available. It was being reduced. We found out later due to we were instrumental in getting the Office of Performance Evaluation to do a study on the Optum contract to try to understand what was happening with this particular service. And we were somewhat surprised, all of us, to learn that the contract was developed specifically to reduce this service because it was becoming so costly, and it was the only service being accessed because it was the only service available. So you know, working with the department and Optum and bringing in the parents' voice, as Jen mentioned, the families that were in crisis and the increasing number of families in crisis, we were able to then merge that information with the lawsuit that would have new services that are going to be rolling out under that will then ultimately be managed under Optum as the contractor.
Right, and so to avoid confusion, the lawsuit mandates that the state implement an array of services to meet that severe emotional disturbance criteria for children, and it's to be done within a five-year period. We're about 3 years into this. We have yet to implement any services. As of January, the first service to roll out will be respite. So we come to the table right now, that service comes out of our Children's Mental Health Program. And so what our role at Idaho Parents Unlimited is to ensure that parents are aware of the different avenues that they have to, that they go to in order to receive any of these types of services. So through the lawsuit, they have to implement an array of services that currently don't exist and will eventually be under the Optum Idaho Managed Care Program. So that merge will help to eliminate the increase in crisis that we've seen, but of course we have a delay in that timeline. So as a result of our bringing some concerns to the table, we identified some services that will be rolled out through that lawsuit that we might be able to access today because they're somewhat available. And one of those services is therapeutic foster care. And right now, the only way that parents can access that service is through a punitive process, which is managed under our Family and Community Services Department through Medicaid. And that would be through CPS and Child Protective Services. And that would currently families would then are forced to go on a registry of neglect and abuse if they were to access that service in order to stabilize the child and stabilize the home. So we've been able to convince the department that that should be a service that we could tap into today. They've identified that as a service to be rolled out through that lawsuit in the future. So we're now in the stages of implementing that service for families and removing that punitive process so that they can access it through Children's Mental Health. They've decided to make it a state plan service, so any child Medicaid eligible who meets the criteria would be able to access that, and it would potentially be a short-term solution for a long-term result of accessing services and treatment options.
And it's only through the family voice and the collaboration that we've developed with both the agent, with Optum as well as the department, that these types of services and policies can be affected so that we truly get to better family stabilization and positive mental health outcomes for our kids.
And we do have an additional parent advisory committee now that the department developed for this Jeff D. lawsuit implementation. So we now have families representing both of those avenues, and these are parents statewide. So they're able to bring a perspective of what it's like to be in those rural communities without access. What is it like? What does it look like? When there may be different philosophies throughout the state. So it's critical that they're involved, and the Department of Health and Welfare has recognized that as a huge benefit.
And so the next steps, just to finalize this, as a result of all of this work, we have now developed monthly coordinated collaborative meetings with both the department as well as the managed care organization. We asked for and had a wonderful meeting with Optum's executive director and their medical director to continue to bring the voice of the families forward, and that is going to be an ongoing collaborative meeting now. We are able to report on the outcomes of the new services. That's something that we'll be able to follow through with. And then we've developed some new linkages, both for families as well as our organization, with other managed care organizations and other partner organizations in the community, not just around children's mental health, but including children's behavioral health, that are literally happening on the spot. In fact, last week, one of our nonprofit organization in the state received a Robert Woods Johnson Foundation grant to improve access to behavioral health, and immediately, I think Jen was the first person they contacted.
Yeah, so when they contacted us so Idaho Voices for Children, so the advocacy group under Janice, contacted us to participate and be at the table to help transform Idaho's behavioral health system through integrated care and increased access. And to go a step further, the sole purpose would be policy. It would be at a state level and potentially at a federal level to help improve the care and address disparities and inequities within Idaho's system.
And then the other linkage that we just created as of yesterday, which is pretty exciting, is there is the organization that handles our developmental disability assessments for children is putting in a proposal to become a single assessor for also children's behavioral health. And so we are going to be collaborating with them on family voices issues, both for the DD side, children's mental health, and those who are dually diagnosed.
And parents will be at the table through that process and have already reported positive feedback for having that one assessor for both dual diagnosis, developmental disability, and mental and behavioral health.
And so you can see that obviously having families at the table as well as a coordinated effort of the family organization, Idaho Parents Unlimited, how important that is for systems change and developing those policies that truly lead to better outcomes for all of us.
Right.
And with that, we will pass the torch to Joni.
Thank you so much
for the opportunity.
Thank you. Yes, I'm Joni Bruce from Oklahoma Family Network, and we're very privileged to have a number of agencies in Oklahoma who have really begun to understand the importance of engaging those that they serve. For the past 10 years, we've had a Family Professional Partnerships Conference, so a lot of the opportunities I'm going to share with you today, a number of them really came out of that conference, and just both families and professionals learning together the importance of working together to better systems, and therefore people in Oklahoma have better lives, especially if they have a special health care need or disability. And I'm going to highlight just a couple of things, issues that we've had in our state, and how we collaboratively with other organizations and agencies have worked to make the needs go away, or at least lessen somewhat. Several years ago, we learned that the TEFRA program, which we don't have a Katie Beckett waiver in Oklahoma, we have a TEFRA program that is a state-funded program that was done legislatively. But we kept hearing from families it was so hard to access. In fact, in 2011, there were only 385 children who actually had access to it. And yet what our legislators had envisioned was that for families who often were finding themselves amidst medical bankruptcy or owing large amounts of funding to different health organizations, their hope was that it would alleviate some of that pressure. Between the years of 2011 and 2013, our Medicaid agency, a number of family advocates, our Department of Human Services, which houses our children with special health care needs from Title V, and also child health from our Medicaid agency and our Department of Health met for 2 years just trying to figure out how can we help kids get the services that they need in a way that isn't going to keep causing a lot of pressures for the families. And in 2012, our NASHB hosted Children in the Vanguard meetings. In fact, we just had our last one this week that Oklahoma was a part of, a grant, and they invited advocates as well as the Medicaid agency, and then later down the road added Title V to see how we might improve access for children in the states that were a part of that project. And in Oklahoma, it was decided among the advocates and the staff from our Medicaid agency that we would choose TEFRA as a priority because improving access to TEFRA would really help improve access to people who were on the waiting list for developmental disability services potentially, and then other families that had children with very high medical needs. And we knew that if you could really help those children, you would end up helping all children, most likely, as you not only work on access to our Medicaid program via TEFRA, but then also just having opportunities for policy changes. And so in 2013, our governor began what was called the Blue Ribbon Committee to address the number of children and youth and adults on the Developmental Disability Services waiver wait list in our state. It's all in the last several years, it's been more than 7 years long that people are waiting. And those are people who really do most likely qualify for those. And TEFRA was one way to support people while they're on the wait list if the children were under the age of 18. And so we looked at TEFRA just to see if there was a way for it to help support some of the people on the wait list. One of the things that we found, some of the outcomes, because of all of that work, I think one of the reasons it was at least somewhat successful is because there were so many different places where we were all working on access to care for kids who have very high medical needs. And really, a number of the agencies weren't even aware of how difficult it was to access TEFRA. And so what happened was we have two agencies, the Department of Human Services and our Healthcare Authority, which is our Medicaid agency, that actually worked together to streamline the process for applications. And those applications were really looked at, and things were removed that they didn't really need. Addition to that, they never captured email addresses. And so if they lost an address of someone and they were on the wait list or they were going through the process of trying to access TEFRA, the only way they could access them was by phone. And so adding those email addresses and also the email addresses of the workers really helped to improve the process of accessing TEFRA. And then documents were developed by both agencies along with advocates at the table to really write out, here's the process, this is how it works. And because the agencies had streamlined that process, it certainly made those documents easier. They're now available on both of the agencies' websites as well as other family advocate organizations like Oklahoma Family Network. The brochure was also reworked by the Family Advisory Committee that is part of our Medicaid agency. And so hopefully we made it in a way so that once people get a copy of it, they understand what it means because it's in normal family language. So the number of youth on TEFRA in 2011 was 385. This summer they put out some data from our Healthcare Authority that stated that 688 children were receiving services. So we had a huge increase, which we know that really is helping families. That's what we're hearing from them. Additionally, a private Facebook group was developed by a group of advocates to provide advice and also assistance in the process of accessing TEFRA, and then even after people were on our Medicaid, just helping them access services. There's been a larger awareness of the navigation process. There are more advocates that are really reaching out, trying to help families work through that process. And then advocates are still involved in sharing emerging issues through the Family Advisory Council at our Medicaid agency. And so this is a slide, and we'll get all of these, and I don't want to run out of time for questions. But you can just see there are there were 560 youth who received services because of TEFRA in Oklahoma. The second process I just wanted to mention briefly, and this has been very recent, is with regard to private duty nursing for children in Oklahoma. Just the number of nurses available has declined over the years, and a big part of that was because our agency simply was not paying at a rate that was anywhere near what Medicare would pay or a hospital would pay nurses. And so a number of advocates worked together. We partnered with not only our Medicaid agency, the Member Advisory Task Force, which is the Family Advisory Council for the Medicaid agency, and then advocates from the Oklahoma Association for Hospice and Home Care Directors, and then our University Center for Excellence on Developmental Disabilities. But we all met and at different times and together and looked at, how can we increase the awareness of the needs of families, because most kids who were qualified because of their health needs were not getting the nursing that they needed. And so we were hearing from families that they were going nights without sleep, night after night, and it might be a single parent, and how that was affecting their ability to work and just care for their child. And I'll give you the long story short. We just found out this week that our Medicaid agency has actually suggested to the board of directors that they increase the rate of pay. And I have no doubt that would not have happened had advocates not raised their voices to let them know that this was a concern, and then partnering with the provider agencies as well as the agency and then other advocacy groups raised the awareness enough that people said, we need to do something for these families because they're not able to sleep. And if you can't sleep, then you can't care for your child. So some of the lessons learned is we have to look outside the box. I don't know that we would have thought to go to the Provider Association. There's actually someone from our Medicaid agency that encouraged that collaboration. We also know when needs of children with high medical needs are met, it will improve the care for all kids. Our organization knows that we need to develop relationships not just with our Medicaid agency, but with our private insurers as well, and then bridge that Family Advisory Committee for Medicaid maybe to those insurers, or perhaps help the insurers develop their own advisories. And then lastly, we have a toolkit that was developed when I was in Maternal Child Health Public Health Leadership Institute on just starting a family advisory committee and managing it over the years. Thank you.
Thank you so much to all of our speakers. We're now going to begin the Q&A session. We did receive some great questions for our speakers in the chat box throughout the webinar. And our first one, we're going to ask a clarification question. So we did receive a question for Delaware, and that is, how long are the MCO calls in Delaware each month? And can you talk a little bit about them?
Yeah, we schedule it for 2 hours, and our policy is that if we finish and there aren't any additional questions, we hang up after the first hour.
Everyone likes an efficient call. That sounds wonderful. If you have follow-up questions, please do chat them in the chat box. We also received, if this kind of thing isn't happening in someone's state or jurisdiction, and this is for any of the speakers, or your health plan isn't having some sort of family input on their work, what would be the first step that any of you would take, and what would you give recommendations to those in that jurisdiction?
This is Jennifer from Idaho. So something that we did, one of the programs that we were not able to really tap into until just recently would fall under Family and Community Services, so that was our Child Protective Services. And one of the things that we recognized by not being able to tap into this program was the discrepancies statewide. So the varying issues, but also differences in different regions and how they were actually working with families or not working with families. And so we went directly to the top. We decided not only would we include one of our legislators, but we include the bureau chief, and so and also the director of FACS, so Family and Community Services. And by doing that, this also came off the tail end of an office performance evaluation for Child Protective Services as well. So they were charged by our legislators to fully implement and a complete overhaul of training modules, training statewide, also including families, including advocacy agencies and different state agencies to come to the table. And so knowing that that was happening on one end, once we jumped in and went directly to the director, we included a legislator who's been really active in this area. We got immediate results. And so now as a result, we meet quarterly with all of their team and then a couple of our staff, and they give us updates on all of the differences and the things that they're improving on, as well as meeting that Office of Performance Evaluation requirements. And then we provide them with input and feedback of what we're seeing statewide, whether they're based on improvements or if we're still seeing some barriers and issues.
And I think what the end result of that is we simply picked up the phone and called a meeting. And so, you know, if it's not happening, there's no reason for it to not be happening. You can certainly just request a meeting and, you know, explain what the issues are and hopefully get the ball rolling.
And I honestly incorporated my own personal story. And then I had a whole stack of stories. So before we had the first meeting, I included parent stories statewide of what it was like to go through that process with Child Protective Services, whether it was false accusations, whatever, anything. But I had a whole pile, and so when we sat with the director, I mean, it was hours that I went through every single story and said, this is what it's like. So they were
Motivated.
Very motivated, and now as a result, we have this commitment with them.
Would any of the other speakers like to, or Family Voices like to add anything?
Well, this is Ann in Delaware. We found out a long time ago through National Family Voices, actually, that every state has a medical care advisory council of some sort, maybe a different name. And that is, we got involved on that, and we still are. And we're able to hear about issues and share that with families and then discuss on the call as well. And the other thing that I neglected to say, that Title V, which is housed in our public health department, has always and continues to be, pay for the phone line for these calls for all these years. And they're a big supporter of that. But when we need to know something about families, opportunities, we do go to Title V. We work very well with them. And we now have families who, because of a call, when the MCOs were looking for members for their family advisory councils, they went to the people that have been calling in and speaking and advocating, and they tapped them for the councils.
And this is Joni. There's just one other thing I wanted to mention, and that just is, and we touched on it a little, but the power of stories. Because until advocates started sharing stories of families, of their own stories or of other families that they knew, our agencies, they knew there were issues with, the private duty nursing, but just no one had addressed it. Because you're talking about a small percentage of the population, but there are a percentage of the population that tend to cost a lot of money. And, in our case with private duty nursing, if they had that at home, it kept them out of the hospital. And so until that association and our Medicaid agency started hearing stories of how it was affecting people from not being able to work, not being able to sleep, how the parents' health had started to really diminish, it took a while. I mean, this wasn't something that happened, overnight, but until those stories were shared so that they really heard how it was impacting the citizens of our state, nothing happened.
Thank you so much for the great conversation there. It's really wonderful to hear that, frankly, just picking up a phone and calling someone and asking for a meeting is a wonderful first step and something many of us can do, as well as sharing our personal stories. I think that that's so powerful, and thank you so much for giving very actionable steps for our participants. I think that we are getting close to time, so what I'm going to do is pass it back over to Risha, who is going to tell us about next steps. Risha?
Great, thanks so much. So we've chatted the link to the evaluation survey for today's webinar into the chat box. And we'll also be following up and sending it as a link shortly after we end the webinar today. Please take 5 minutes to fill it out. It really helps us as we plan more of these sessions. We will be following up with the slides from this presentation and any other resources that our presenters might want to share. And the recording will be up on ASTHO's website in the next couple of weeks, and we'll let you know when it's up. And 2 new resources will also be available in the coming weeks. A case study highlighting the work of Oklahoma to engage families as partners in their Sooner Care program, and a state story about New Jersey's work to increase family engagement for underserved populations. We will be sharing those links as soon as they are up. Thank you so much, and have a great afternoon.